carcinoma of buccal mucosa. So my patient presenting complaint is wound, bed sore with first degree, mortal and bloated skin, especially the hand and feet and key. Patient complaint also drowsy, poor intake, unresponsive of upper limb, lower limb, cognited lungs in left side. Blood pressure is decreased, less urine output, and also restlessness and also difficulty of breathing. And then history of presenting illness. A 65-year male patient complaining of carcinoma buccal mucosa, admitted in palliative center unit. Above mentioned the complaint is last 1 week. Now male patient complaint of tetering tumor and especially with the poor difficulty of diagnosis. Then a reconstruction of below the amputation. Now on examination is heart rate is 50 to 60 breaths per minute. Blood pressure not recorded. Required oxygen support. On room air is oxygen presentation is 60%. Urine decrease. Complaint of constipation, poor intake. Then treatment and significant investigation, urine blood and blood test, ultrasound scan, MRI scan, CT scan, low protein diet, and diuretic. Okay. Psychosocial accept. Patient having blood pressure recorded, not recorded, retention of urine, and sodium retention. So on treatment, patient on injection pad 40 for 5 days. Injection paracetamol 1 gram per BD. Injection meropenem 500 mg in TDS. And patient having also intravenous fluid NS plus injection UMI 80 ml per hour and oxygen support. So my main concern in this patient is low blood pressure, increase the intake and increase output also, and low calcium level. Main concern for that patient. These 4 topics. Then summary, patient having diet therapy may be extremely complex. Untreated severe kidney disease, wound care. And, now discussion point is how to manage caregiver about the condition, because patient family member not acceptancy of the that symptom, and also how to handle the socio-economical situation of the patient. What is the health challenge to the patient? What is the counseling patient about the rehabilitation of the patient? How to give psychosocial support of the relative after die? Please repeat the discussion point.
Radha ma'am, Shiva ma'am has not joined yet. She will be joining in a few minutes.
Yeah, discussion point, sir.
Okay, good afternoon, everyone.
Good afternoon.
Thank you, Brother Dattatreya, for presenting this play. It's appropriate one. Once we have the session, all of you will be able to answer and discuss the discussion points. So mainly how to manage the caregiver or how to convey the caregiver about the actual situation, how to handle the socio-economic situations, then what are the health challenges. Because this is, Sangeet, if I'm not wrong, this is the last session for this batch, right?
Ma'am. Yes, ma'am.
Yes. So you have had all the sessions with which all of you will be able to answer and manage. And last 2 are how to counsel the patient and how to give psychosocial support for the surviving family. How to counsel the patient, you see, at this stage, you're not going to counsel the patient, no, about rehab. I think that points alone may be slightly inappropriate. As we go to the discussion, we can go into that. In that case, can we go on to my presentation, Sangeet, then?
Yes, ma'am. Then we can discuss these points.
Yes. Finally, when we finish the topic, see, basically today's topic is again, it's going to be end of life care and ethics. And in that also, how I'm going to take you all through the cases which will incorporate end of life care and the ethics will be incorporated both into the whole thing. And some more salient points for end of life care also we can see. Okay, next slide, please. So, what are the learning objectives that we are going to have? Discuss transitions in an illness trajectory of life-limiting illness. So, from that point, what is palliative care? You've all seen. So, it is an approach of care for anyone who has life-limiting or life-threatening illnesses. So, disease and illness, so far you've all seen the difference. The disease per se is diabetes, hypertension, all that. Illness is the person within, like it is a person inside the patient, that is what who undergoes all these sufferings. So that is the part, it is basically a character or the quality or the effect that happens to a person. And then explain the principles of biomedical ethics and their application in end of life care. So that is why I said we are going to have case discussions through which we will see both end of life care and biomedical ethics incorporated in it. Then explain the existing legal provisions and national level policies that are available in India to help and facilitate normal end of life care. And discuss the concepts also of DNAR and advanced care planning. Next slide, please. So this is how, like, transition in chronic illnesses. If you see this slide, and if you go from left to right, so you can see diagnosis. What happens through the phase of any illness? That is what is given in this. So basically, when someone has any symptom, be it some simple symptom or a gross symptom which is affecting their day-to-day, any stage of their life. Why I'm telling these two is, it could be either cancer or non-cancer illnesses also. That is why I'm trying to explain both. See, in all these 17 sessions, you would have known that palliative care is both for oncological illnesses or life-threatening or those type of diseases, and also non-oncological diseases. It could be chronic kidney disease, chronic lung disease, dementia, paraplegia, or stroke, or any such chronic illnesses. So any illness you take, it will move from, as shown in this picture, from left to right. On the left side, you can see diagnosis. That could be the early phase of the disease or illness, when nothing is clear or nothing is sure. So then it goes on with investigations to final diagnosis. Then you see the second phase called as disease containment. So disease is being managed. Disease containment means disease is kept under control. So on that stage, normal maintaining of function may be there, but in that also you can see one dip. That shows they may have some states or some short periods where they may not be able to maintain their function. And then next comes decompensation. When in that phase, you've got more dips. Okay, and also you see the whole gradient, it is going downwards. So you're seeing a decline. Then next, dependency and symptoms again. So slowly, the red ones are showing some individual episodes or something like that, which is causing impairment of their normal functioning. So before that, they were independent. Slowly, they may become dependent with symptoms happening frequently. Then you see the next phase is decline. So when the dependency increases or the symptoms increases, then there is a very significant decline. And that is when they go into the terminal phase of the illness. Then you have death and bereavement. So the terminal phase of illness was in the past, that is where you have the option of hospice type of thing alone coming in. End of life care alone could be. So as we always say, hospice is part of palliative care. And you also have death and bereavement. Next slide, please. See, the same thing what I explained in the previous slide is given in a more user-friendly, I would say. If you see this graph, you can understand the same thing in a nicer way and easier way. So in this, you have got four important information given with four graphs. The first one, in all these graphs also, one common thing is that the vertical line is the line which shows the functionality. And then the horizontal one is the time or period. So if you see in the first one where sudden death is one, these are the four common proposed trajectories of dying. So if you take the whole population, everyone will fit into one of the four. Which one? None of us know. So the first one is something called a sudden death or a sudden fall. So in this, if you see, the functionality is very high. Some common examples are accident or a cardiovascular collapse. So in this, you see the functionality is high. Basically it says that they could be carrying on with their normal routine as they would normally do, and suddenly they may die. So this one, only 7 to 10% maximum of the whole population, 7 to 10% only. This is all statistical figures. I am not making up anything. So these are statistical figures which say that 7 to 10% of the population may have this type of death. Second one is terminal illness. In this also, you see the functionality is quite high, but this is called as waterfall effect. You see at the end of it, what there is a sudden drop, but at the same time, it is not as sudden as the sudden death. So this one common example is malignancy or cancer or oncology, in which they have normal functionality, but their decline is quite rapid. This nearly 15 to 20% of the population may fit into this category. Then the third one is quite an important one, organ failure. It could be any organ failure, cardiovascular, respiratory, kidney, neurological. So any system failure will all come into this category. So in this, if you see, few salient points are the normal functionality itself is not high. You saw in group 1 and group 2, the functionality was quite high. Whereas because of the chronic nature of the disease per se, the functionality itself has come down from high to slightly lower. So basically what it says, because of their underlying disease, their functionality may not be normal or may not be very high. Sorry to say, may not be very high. So starting point itself is slightly lesser, and each episode of illness, for example, they may have a pneumonia or they may have some other form of infection or some metabolic derangement, anything they could have. So in those times, each episode is denoted by the dip. Every time they recover, but when they recover, they don't recover to the state where they started. You see, after the third dip, that is third episode of infection or any third episode of hospital admission. See, after the third episode, they come back, but the amount where they come back to, if you extrapolate it to the vertical line, it is nearly 50% functionality lower than their start. So this is something to be kept in mind, because every time such patients are unwell, come into hospital and go, it is our duty to tell to the family and the patient that their functional capacity is coming down, and that shows that their organ functioning, or we say their organ is becoming more and more decompensated. That means what? It is unable to correct or come back to normalcy. So this group consists nearly about 50% of the population can fit into this. And then last but not the least is the one which is frailty. That is people who are 80, 90, 100. Nowadays, we see many 100-year-olds. If you see their function is way too low to start off itself. And there will be a gradual, slow decline. Again, this may form up to 10 to 15% of the population. So that is how the whole population will fit into one of these four. Is this clear to all? If anybody wants me to explain or take them through any of these, one of these graph or all of these, I don't mind, but it is very important that all of you understand this, because all the patients you see will fit into one of these four. Any doubt, anything put in the chat or anything, Sangeet, you may have to check for me.
Okay, ma'am, sure.
Okay, if there's no, if anybody wants to raise your hand or ask anything, please do.
You can ask your doubts in the chat box as well. I will read out to the faculty.
Okay, if not, next slide, Sangeet. Okay, now coming to, so as I said, we are going to see the whole ethics and end of life care together. So first, what are the cardinal principles of medical ethics? Autonomy, beneficence, non-malfeasance, and justice. Beneficence means do good. Non-malfeasance means do no harm, do not harm. Justice is truthful or just use of the resources. That is what comes under justice. These four main cardinal principles of medical ethics have to be followed, with the three things mentioned on the right side also. You should follow truth telling. You should follow or give due respect for life and give due respect for the person also. Along with that, the next, if you click once more, Sangeet. You have to follow, you have to give due dignity for the patient and be honest in whatever you do and say, and always follow clinical integrity. So this slide is very, very important because it gives you the whole nutshell of medical ethics into it. Next slide. So this we are going to see with the following cases. Case one will be, there's a 78-year-old woman with stroke, hypertension, and type 2 diabetes. She is already cachectic, she's bedbound and dependent for all activities of her daily living. Basically, that means what? She cannot do anything for herself by herself. And she's brought into hospital with reduced urinary output and reduced oral intake. She was diagnosed with urinary tract infection and end-stage renal disease. She was advised antibiotics and dialysis. The patient herself, she says that she does not want further treatment. Patient refuses, while the sons want her to undergo dialysis because she was told she needs antibiotic and dialysis. But the patient says, no, I don't want to have anything more. But the sons force her, or they force her and the medical team that she needs to have everything. So what will your take be? How many would say that she definitely needs to have dialysis, and how many will what other option would the rest want to take? Type on the chat box or unmute and say anything is fine, because this session, if you are all not going to be interactive, you are not going to take anything best out of this. So how many would say that, see, patient refuses while sons want her to undergo dialysis? How many will go with the patient? And how many, what other choices the rest of you would like to take? Don't have any hesitation. Right, wrong, whatever it is, you have to say. Otherwise, we can't, it won't be worth moving forward. Because the case what you had also will be somewhat the same. Someone has said go with the sun. Go. If they type, I can see only. No worries, Sangeet. You also keep an eye. He has said that he will go with the son's wish. How many will go with the patient's wish? Okay, next, what do you all understand by the word autonomy? You can all, you can unmute and speak also. Not necessary that you have to type only. Anything is fine. Hmm? Yes, yes. Speak. You're still muted.
Actually,
Unmute and speak.
चलो क्लास खत्म होती है
Huh?
Pooja ma'am, do you wish to convey anything to the faculty? No ma'am, I think it's unmuted by accident.
Exactly, because something they're talking within themselves, I think. Okay, what do you all understand by autonomy? Okay, autonomy means is freedom or independence. That is what is autonomy. Basically, what the patient likes or wishes to do, giving the opportunity for the patient to do what the patient wants. That is autonomy. So, having understood that word, any change in your call? How many of you will go with the patient's wish and do, or how many? Only Manjula typed that they will go with the son's wish. Okay, Manjula, go with patient wish. Rita D'Souza. Can you say why do you want to, Rita? Can you say why do you want to go with the patient's wish? And Manjula, why do you want to go with the son's wish? Just unmute and speak, both of you. Just tell why you want to do. Then I will explain for both.
Ma'am, this one autonomy you just now said no. Please repeat, madam. After that, I will tell.
Okay, autonomy means it's freedom or independence. I have the freedom or independence to do what I wish. That is what is autonomy. Clear?
Yes, ma'am.
Patient has the wish. See, for example, simple ways I tell everyone. All of us want to wear the dress what we want to wear, and like for little things, we say we want independence. I want to be the way I want to be. So the same thing for life also. No, every one of us have the right to know, right to ask, right to live the way each one wants to live. So that independence, that freedom is autonomy. Is that clear?
Yes, ma'am.
Okay, now having made that clear, what now both of you, if you could explain why you want to go with the one person said they'll go with the patient, another person said they'll go with the son's wish. Tell me the reason for both.
Ma'am, in son's side, we are thinking means in sufferings.
No, why did you say son's side? You are Manjula, right?
Yes, ma'am. I'm telling in son side, we are thinking means he cannot see the sufferings of patient. No, that's why I told.
No, already he's seeing the patient. No, the patient can't do anything. The patient is requiring help for every activity. She's bed bound. So,
Yes,
so that situation. We have to find out whether the son has understood what the situation is. First,
yes.
find out if that son, who is the full carer for the patient. If
Yes.
this person was not at all with the patient, that's what we have to
Yes.
find out more about the son's knowledge, understanding of all the patient's condition, everything. Only then, first, whether he has understood the patient's condition. See, she is cachectic, means already she is skin and bone. Bedbound means she's not getting up at all and dependent on all activities. She cannot do anything for herself. And also already she's on end stage renal disease. So whether the son understands the condition of the mother, just because he wants her to have, does he understand? And has he had any communication with the mother at all? So all this we have to find out. You're telling he cannot see her suffering, means if she has dialysis, will she become all right? Is that what is your understanding about that? Because she has got end stage renal disease, no?
Yes, ma'am.
What is end stage renal disease?
Now, no treatment.
Very good.
Yes.
Don't think I'm questioning you. Lifelong you will not forget this. Okay?
Yes. Yes, ma'am.
I'm not doing this to corner you or make anything in the wrong way. Only
Yes.
to make sure that you will understand, and lifelong you will never forget. So very good. Thank you very much. See, as you said, in stage, no treatment. So in that stage, many times what happens, due to love and affection, they may not know what the actual problem is. But simply they may be thinking, do dialysis. They may be thinking dialysis may correct. But we know as medical professionals that she is in end-stage renal disease and dialysis may not help her. So our job there is to explain to the son so that he understands, and then ask him what he will want to do. And then talk to the son separately, talk to the mother separately. And thank you very much, Manjula. Rita, then why did you want to go with the patient's choice? What was your take? Sangeet, it was Rita, right? Rita or Ritu?
Yes, ma'am. Rita D'Souza.
Rita D'Souza. Okay, we can't waste time also. All of you, whenever you type or think, better that you speak because it's for your benefit. The main thing why we should go with the patient is patient has all the right to have treatment or what is, because the patient is the person who is undergoing all the pain, difficulty, illness. See, in this case, we have seen that she's already bedbound, not able to do anything for herself, and she only job for us is, we will see in the next few slides also, we have to make sure that the patient understands everything. Patient understands her condition, is aware of her condition, is aware of her prognosis. That is our duty, to make sure that the patient understands everything. And then if she makes a decision, then we have to go by with her decision only. That is autonomy. Next slide, please. Okay, then comes, will you advise, what all I asked you only is going there. Will you advise the patient to have dialysis? Will you avoid talking and discuss the treatment with relatives alone? So no, we should do as I told you, explain to the son separately, explain to the mother separately, and respect patient's wishes. And here, will you refer her to a higher center? No, because already she is end stage. All they have seen already, this workup and all has been done, that she has end stage disease, not correctable disease, and all these have already been done. So you need not refer her to a higher center. Next slide. Okay, only as I was telling, if the patient can understand, do everything, so far what we said is fine. In those situations, what happens? The doctor, patient, family, all together, because the doctor explains to the patient separately, family separately, and then together to everyone about the prognosis, and also what will happen if we do, what will happen if we don't do. So, as Manjula said very correctly, it is our duty to tell to the patient, because that is end-stage renal disease, and they've already said that treatment is not going to be successful. So all these you explain, then tell them what are the outcomes, or explain. You have to explain to them what their expectation is and what the outcome will be. So if you do all that, fine. But if then we have to find out, does the patient have the capacity to understand? If the patient can understand, all what you have said above is fine. So why we are doing that? If the patient can understand, then the patient can make the choice, and patient has the right to make the choice. Okay. In that, when you find out whether the patient can understand, you have to see all this, whether the patient is able to reason the benefits, burden of treatment, and also we have to make sure that the goals of care means what are the treatment options we are going to give. What if we give this, what will happen? If we don't give this, what will happen? All these we have to explain, and all this have to be explained in connection or in relation to the patient's condition. Because her disease is end-stage renal disease, even that we have to put some goal of care and tell that beyond that she may not get any benefit. Okay, so her aspiration, the son thinking that dialysis will help, here we have to tell the dialysis may not help. So all these, if the patient can understand, we have to explain, make sure the patient has understood, and then move forward. Next slide. So the same thing is given here. We have to respect patient's privacy and confidentiality. Empathetic truth telling. That means what? We have to tell the truth, but we have to make sure that patient and family will not be in a condition to accept, because to part from any loved one is not going to be easy. So that is why empathetic means putting yourself in other person's shoes, making sure that, tell them that, yes, we understand that it is a difficult decision making, but it is not, you are not making this decision, it is a medical decision, because the medical problem is end-stage renal disease that will not improve. That is why we are making this decision. So that is what is called as, we are telling the truth, but how am I telling? Telling it in an empathetic way, and then giving them informed choices. So once you give sufficient information, when you tell them because it is end-stage renal disease, she will not benefit from dialysis, then they themselves will come back telling that, okay, if that is so, no need to give. So I am not making, I means what? It's neither the patient nor the doctor. None of them is making an individual decision. It is a collective medical decision because of the medical disease. And there is clear evidence to state that if someone is in end-stage renal disease, when that shows that kidney is not functioning, dialysis may not help. Okay. So shared decision making aligned to patients' cultural religious beliefs. That means what? We have to go by, because see, the family has a role to play. So the family should not be ignored also, but you have to explain to the family, and then collectively the decision is made. So this is called, in collective autonomy is the norm in our culture. Why are we explaining and doing? Because in Indian system, the collective autonomy or the family as a whole has a role to play. So once it is explained, then the decision is made collectively by the family. And as this is the norm and that is the culture in India, so better to practice that. Next slide. Next slide, Sangeet. So basically, you have to have conversations like between the patient and the doctor. All that I've explained only is given in a comfortable way. Maybe once, twice in this, on the same day itself, you can talk to them and give information little by little, and then make sure that they understand, come back and move forward. No argument type of thing, but it is to be explained and then give time for each one to think and come back. Next slide. So patient autonomy is to be upheld at all cost in medical ethics. So this is important take home from today's session. That's why the first case itself, the son may tell, but whatever is the patient's wish. I will tell you one little thing here. Think of all of yourself in the position of the patient. If some of you, if any of us want to have one particular treatment option, and the family tells everything opposite, will you all like to follow that? Just think. I'm not going to give answers for all this because it is an individual. See, when you all start thinking like that, you will put your patient also in that position and think. So always patient autonomy is to be upheld. That means what? Is to be respected and followed at any cost in medical ethics. Whatever it is, whoever says or thinks, patient autonomy has the highest priority. That is what is the important thing from here. Next slide. So suppose the next, if the patient has dementia or lacks capacity, cannot understand, cannot make decision, then what happens? Next slide. So far what we thought was everything was fine. But sometimes our medical profession itself, the challenge and the benefit or the charm, everything are the problems. So what happens if the patient doesn't have the, like it is not, patient is not able to make the decision. Patient may have dementia or something like that, where decision making capacity is not there. In those situations, you have a surrogate who makes the decision, which could be next of kin, that is either brothers, sisters, children, or it could be a nominated person. Sometimes, many times, they may not have children or they may not have anyone. So they might have nominated someone, or they may be a legal person, or they may be, finally, if none of the all the three are there also, there is something called as patient's best interest. That is done by the medical team. Okay. So if the patient is unable to make the decision, these options are there. Then above all this, there is something called as advanced directive, which we will see at the end of this presentation. But if someone has already written something, that is something called as a living will. If someone has written something and kept, and we have to follow that, and that will be the final decision making information from which you can move forward. So if the patient is able to make decision, patient has always autonomy or the freedom to make that decision. If not, they someone who has been designated can take. Even that is not there, then always the medical team will do something in patient's best interest. What will be best for the patient is what will be done. Next slide. Okay. Next is how determining best interest is done is you put all these into perspective. The patient's best interest, the person or the team who is going to do it have to make sure that no wrong is done. Always, anything and everything that is done is in patient's best interest. There's something called as risk-benefit ratio. We have to see what are the risks, what are the benefits. Then finally, you make between the risk and benefit what is the best for the patient. That is what is done. Okay. In the next few cases, when we see, you will understand more about the risk benefit ratio. Next slide. Next case is a 20-year-old boy with metastatic osteosarcoma of the lower end of femur who already has lung metastasis and anemia. See, look into each point which is mentioned there. He has a large tumor on his thigh and insists on getting operated. Okay, but both the parents and the patient are adamant that they need the operation. But I will reiterate what are the problems that the boy has. He has metastatic osteosarcoma, lung metastasis, and severe anemia. Okay, and they are insisting on surgery. Now, what should the surgeon do? How many will say go ahead and operate, and how many will say not for surgery? What is the take? The main points to be noted here are the disease, already patient has anemia, and it is a metastatic osteosarcoma with lung metastasis also, and large tumor. So all these points are important. Then so far what I've been telling also, you see the previous slide, what all I said, you have to put all that into perspective and then answer my question. Okay. Next slide, Sangeet. Okay, this is what I was trying to say. You have to think of the risk or harm, benefit is benefit. So what I said as risk, benefit, or harm and benefit. Okay. So in this slide, you're seeing what are the benefits. Okay. Benefit is the tumor will be removed and he may have some psychological benefit. What are the harm? Already he is anemic and it is a large tumor. If you debulk a large tumor, already someone who's anemic can go into more severe anemia. And he will, because he has lung metastasis or it is a metastatic tumor, anesthetic risk also is going to be high. So his risk or harm is more than the benefit. So this is what I was trying to say, risk-benefit ratio. You have to see whether the risk is more or the benefit is more. Only if benefit is more, you will make a decision in favor. Next, click once more.
There is a question in the chat box by Manjula. Surgeon have to explain part outcome first.
Exactly. Surgeon has to. Very good. Yes, that is what. So the main job of the surgeon is to what should the surgeon do? That was the question. Very good. The surgeon has to explain this risk-benefit ratio. So the surgeon has to say the patient and the family want debulking, why, or removing the tumor because that may be causing harm or difficulty in using the limb. Patient may not be able to mobilize. So their concern is if we take it off, he may be better off. That is what they are thinking. But the job of the surgeon is to explain to them this risk-benefit ratio. Okay. And then once you explain to them, give them some time to register and understand and then move forward. Yes, Manjula, that is the job of the surgeon to explain. Next, click once more. So the main thing, that is all what I've said only is there in the slide. So basically it is the responsibility of the surgeon to explain everything and then move forward. So then initially they may not be willing because they are thinking that removing. But if you tell them that the life is in danger, the harm all that you have seen, with all this, the patient will be more at risk of having more complications and dying rather than living after this. So all that if you explain to them, then they may be able to understand and agree with the surgeon. Next slide. The conflict, opinion, all that, no, it is a collective decision and then you explain to them. So as I said, no, the next thing is that non-malfeasance means do no harm. So as any medical professional, doctor, nurse, or whatever level of care we provide, none of us have got any right to do any harm to the patient. So here in this case, if you see, by operating, the patient may end up in having more harm. Okay. So we have no right to do that. So we have to respect the sanctity of life, sanctity or the benefit of the patient. So that is important. Non-malfeasance is the right of the physician. So we have to maintain that we don't do any harm. Okay. In this next doctrine of double effect, we'll see there is some normally when we see that, you'll understand what is the overlap, because all these four things, no, like autonomy, beneficence, non-malfeasance and all, they all may overlap many times. You see this harm and good, no? Some people, when they don't know what exactly it is, for example, this case, what we saw, this 20-year, if someone thinks, oh, 20-year-old boy, very young, he needs to have the surgery. If you're looking at only his age, there you may think you want to do surgery, but there you're causing more harm. So beneficence and non-malfeasance are overlapping there. So in always these four can overlap. That is why this medical ethics is so important in decision making and in end of life care. Okay, next slide. See, Oh, 1 second, go back to the previous one. Non-malfeasance overrides autonomy. What I told you just few minutes ago, there may be overlap. For example, here in this first patient, I said, whatever the patient said, I will follow. If I'm going to follow the same thing and now this patient wanted surgery, no, someone of you could think, even though you're not asking me, oh, what she said in the first one, that you have to follow patient wish. Now patient wanted surgery, but she's not following it. That the answer for that is here in this black and white. Non-malfeasance overrides autonomy. So what? Here, if we operate, we will do more harm to the patient. So we are not supposed to do any harm, no? So in those situations, here it is my duty to explain to the patient that if I go along the patient's wish, I may do harm, which I should not do. So I will have to explain to him, even though you want to have surgery, but surgery as such may cause detrimental situation to your life. So that is why I am not following your wish. So if you explain to them that by operating you may have more complication, then they themselves will change. The autonomy may change. He may say, no, I don't want surgery. So I am not doing anything wrong. I will still follow autonomy, but after explaining to the patient and making the patient understand. So there only non-malfeasance means do no harm. So not doing harm. Any situation, I should make sure that I means any medical professional should not do any harm to the patient. So that is how, so without doing any harm only your action should be. So that is what is said here. Non-malfeasance overrides autonomy. That means you have to make sure always you do no harm in those situations, even if you're not following autonomy. But basically what you're doing, you're explaining, not that you're verbally not following. So that is the important fact here. Is that clear? If there's any doubt, please do ask. Okay. Next slide, please. Okay, next is something called as doctrine of double effect. That is what was there. Basically, what happens is sometimes when you do, like it could be an action or a treatment or anything like that, two effects happen. But there may be one good effect and one bad effect. But the bad effect is not done intentionally. That is what is important thing to understand in doctrine of double effect. The example what is given is performing salpingectomy in ectopic pregnancy. So what ectopic pregnancy is pregnancy happening in the abnormal site. So in those situations when ectopic pregnancy happens, when there is blood in the peritoneum, patient is in a very serious life and death situation. Okay, in those situations, what happens? To save the mother, the tube, ovary, everything is removed. So that's what is explained in this box within. A single act having two possible foreseen effects, one good and one harmful, is not always morally prohibited if the harmful effect is not intended. Okay, in this ectopic, what is this said here? Any surgeon is not intentionally removing the fallopian tube and the ovaries, because the abnormal pregnancy happens in that place. To save the mother, that tube and ovaries have to be taken away. So there are two actions, but the removal of this tube is not intentional. It's not done as a infertility procedure or anything like that. Removing the tube and ovary was not the main intent. Because the abnormal pregnancy happens in that, it is removed. So main thing, two single act having two effects, one good, one harmful. So one good is saving the mother's life of taking the tube out. Other harm is the person loses one tube and ovary. So the chances of becoming pregnant is slightly lesser compared to a normal person. So this is what the action must be in what situations when anything like this happens, it is accepted. The action must be morally good. You must not desire, the negative effect should not be an intentional one, and the good effect must be as immediate as the negative effect. So basically, it is no intentional harm is done. That is the main important thing to understand in this. Next one. Next case, a 57-year-old man with advanced metastatic cancer of the lung, severely breathless due to progressive disease, and all reversible cause of dyspnea have been ruled out. See, each line is important. Okay, 57-year-old advanced metastatic cancer of the lung. Second, severe breathlessness due to progressive disease. All of you understand by the word progressive disease? That means the disease is getting worse day by day. It is not getting better. It is only getting worse day by day. Then third one, all reversible cause of dyspnea have been ruled out. As the first case you saw, no, end-stage renal disease. In this also, whatever like medicines, inhaler, nebulization, whatever reversible causes, whatever like infection, any problem in the lung, all that which can be corrected, correctable, we say. Another way of telling, all reversible causes. So whatever can be reversible means whatever can be brought back to normal. So try all that. So all that have been checked and then they have been ruled out that nothing can be done. Then that type of patient is admitted into ICU for artificial ventilation. What do you think about this decision? With all the above problems, that person is admitted to ICU for artificial ventilation. Okay, to make things clear, generally when people in this, when with all this, they may not be able to make a decision. I generally give a simple another case so that in between these two, then you can make a decision. You have one bed in ICU, okay, and you've got this patient who is there, like the patient who is there on the this slide. Next, I'm going to tell you another patient, 27-year-old with severe pneumonia, otherwise fit and well. That means what? He is not having any other medical issue at all. He was at work. He was working. Suddenly, he became breathless. He was brought into ICU. Okay, 27-year-old pneumonia, breathless, brought into ICU, no other medical issues. That patient is there, and this 57-year-old advanced metastatic cancer lung, breathlessness, all reversible causes ruled out. He is also brought to ICU for ventilation. You have got one bed. What for that one bed should be or will be given to which patient? Type or unmute and speak.
Ma'am, young old patient, we will give the chance to her, ma'am.
No, give the chance to which patient?
Young woman, ma'am. Young woman with
27-year-old patient. Then 27-year-old patient who came with pneumonia. Okay. Thank you. Somebody else. 27-year-old. Ramani Joseph. Is that the person who spoke? No, I think Jennifer.
No, madam. No.
Okay. Okay then. Fine. So thank you. So basically, that is what. See here, no, not only young. You have to see all parameters. Young is one parameter, 27-year-old. Next, what all I said, it's an infection which can be correctable. Next, no other medical issues. Till that day, the patient was working and doing everything. So suddenly collapsed and breathless. So, and there are so many correctable, reversible. You can give IV antibiotics, you can give nebulization, you can do everything and make the patient better. So putting everything into perspective, it is just not one parameter or one variable, we say. So putting all that into consideration, you can see how the patient can be, to decide which patient will benefit treatment. Okay. So that is one of the reasons, and that is how you have to analyze and make the call. Whereas in this patient, see, already advanced metastatic CA, breathlessness due to progressive disease, metastatic lung, no, metastatic cancer of the lung. So already the functioning lung may be very less, and reversible causes all have been ruled out. So there is nothing which can be corrected. So who will benefit from artificial ventilation? The 27-year-old may benefit. So that is how you make the call. Next slide. Yes, so we have already seen. Next slide. So why this justice is something? Am I taking this decision just because I wish or you wish or any XYZ wishes? No. Okay. Healthcare is a scarce resource. It is not only for one part of the world. The whole world, with the current population present in the whole world, healthcare is a scarce resource for any part of the world. Don't think that these things are happening only where you are. It is happening all over the globe. Okay, because healthcare and treatment is a costly affair, and plenty of people are there now. Everyone needs justice. Everyone needs care or health support when required. Next, equitable access to resources. What is that X can get, Y cannot get? X can get everything, Y should not get anything. Nothing like that. So whatever is available should be used properly, appropriately. That is why we make this decision. Who will benefit and who has the maximum chance of benefiting? Then you get that person deserves. So that is what is a wise use of resources. So are we allocating that precious resource of ICU justly? That is what I said is only mentioned there. Are we considering the family resources also? The fourth point is another important thing. Because, see, for example, the 57-year-old who had metastatic CA, you put that patient on ventilator, and if it is a private hospital, and make that family spend another 20 lakhs, because see, all what you saw cannot be correctable. All reversible causes seen cannot be done. So you have seen that the patient will not benefit, but still you put means, what are you doing? You're putting the family's resources under challenge. So that is why you have to see wise usage of ICU resources, wise usage of the family resources also. Because if you're going to make the family indebted, then what will happen? How will the surviving family survive for the rest of their life? That also has to be considered. So basically, ethics is knowing the difference between what you have a right to do and what is right to do. Okay. So that is why you have to gain more knowledge and information on all these things, and then finally decide. As I have taken you through all these, makes you understand what it is. So if you understand all this, at the time of end of life care, you can make a wise decision. Next slide. So main thing is the fair allocation. All what I've said, only it is the duty of the physician. It is duty of the person, then country. You can go on and on. It is basically all of us have to. It is everyone's duty to make sure the resources are used wisely. Generally, the first line alone, what it says, end of life care consumes 10 to 12% of all healthcare expense. That's why, as I said, this is a global phenomenon and global expenditure. Next slide. So, basically, as I said, we have no right to make the family spend on something where it is not going to be useful. That is what I explained. For that same 57 metastatic CA, you explain everything. That is what is given in this slide. So we should not do that. We have to make a wise clinical decision. Next slide. So the next few slides, are some salient points, because these decisions normally will be made by the medical team. That is the doctors and nurses together, and mainly the doctors. But if you all understand the main thing, no ethical difference between withholding and withdrawing. Basically, there are two things called as withholding treatment or withdrawing treatment. Basic both are when the patient has reached a condition where the outcome or benefit or treatment will not be helpful. In those situations, withholding or withdrawing is done. They are two words with the same meaning. So both are same. There is no ethical difference is what is mentioned here. Next slide. What is euthanasia? Euthanasia refers to intentional act of ending a patient's life by medical means at the request of patient or family with an objective to end or avoid suffering. It is not legal in India, and it is always an active act, and it is not a passive act. It is a deliberate action. That is what is important to know. And with the previous slide, what I said, withholding or withdrawing, that and euthanasia are not the same. Please very clearly understand. Withholding or withdrawing is you just stop the whatever extra treatment. For example, putting a patient on ventilator, avoiding or not putting the patient on ventilator is withdrawing or withholding. After that, we don't do anything. Just let nature take its time. Whereas euthanasia is an active act, as you see, in the intentional mode of ending. That don't confuse withdrawing, withholding, and euthanasia. They both are different. In withholding or withdrawing, nothing is done. You just stop whatever you stop or don't do anything and leave it for nature to take its time. And euthanasia is not the same. Euthanasia is an active mode of ending, and it is illegal in India. It is not practiced. So that much, if you understand, that's enough. Next slide. Rest mono is just salient points alone, I will say. Recently in India, next slide, Sandeep, there's something called as Advance Medical Directive or Living Will. This alone, all of you have to be aware of, because January 2023, in India, there is a legal document which has been made, and all information is available in Pallium website. This is what it is someone, for example, we saw the first case, some 60, 70, 80-year-old has made up their mind that some treatments they like to have, some treatment they don't want to have. If they are clear in that, they can write and keep what is their wish and will. And recent change in legal procedure is, if they write and keep, and it can be attested or signed by a notary. That is enough. Before, it needed to be signed by a magistrate. That change happened in January 2023, making this advance directive or advance or living will, it is called. It has been made easy for people to write and keep. So why is it done? The purpose and object of advance medical directive is to express the choice of a person regarding medical treatment in an event when he loses capacity to take decision. Okay, that means what? First case, when I said, if the patient is able to make a call and say, I don't want treatment, fine. But suddenly that patient develops dementia. So person, he or she loses the ability to make the decision. In those situations, if they've done an advance directive ahead, it will come handy. So what does it say? It helps to make a decision on treatment, then he or she loses capacity to take a decision. So that is the importance of advanced medical directive. Next slide. It is a legal document. It is created by the patient, explaining what they wish and what. For example, they can write, I'm willing to have some basic treatment. I don't want NG tube. I don't want this. I don't want that. I don't want to be resuscitated. If I have a heart attack, do not resuscitate me. So those type of things which can be expressed and kept. And the next important thing is last, guide the medical profession and family about medical care. No point in someone making the advance directive. They have to explain it to the family, because they might have done an advance directive, but then like the first case, son may come and say, no, my mother has said everything. No, you do everything. So it is the duty of the mother to explain to the son also. This is my decision. I have made it clear. Please, you don't come and cause trouble to the medical team. This is what is my wish. Please allow them to do what I have mentioned in my advance directive. So it is the responsibility of the person to inform the family also what it is, so that it will be a collective decision. And at that point of time, there will not be any difference of opinion or misunderstanding. Next slide. So for all this, we have plenty of guidelines made by experts in India in all forms. You have doctors, legal lawyers, social workers, human rights people. Everyone is involved in making guidelines, and these guidelines are made with so much keen interest that it is always patient's best interest is only kept in mind. That's why they have people from different walks of life, like doctor, nurse, lawyer, and like even in doctors, they have different field of people, like intensivist, general physician, so that everyone puts into perspective patients all details, and then these decisions are made. There are plenty of documents regarding all this in Pallium website, which can be very helpful. That's it, Sangeet. You can come out of the screen. Thank you, everyone.
Thank you, ma'am. Thank you for the wonderful presentation. Can we move on to the discussion points, ma'am?
Yes, go on to that. And also, if anybody wants to ask anything, they can ask. Yes. So everyone can, we can go one by one. How to manage the caregiver, or what is that of the second, that person won't be there, no? 4 o'clock, you said.
Yes, ma'am. Datarate.
Okay. No worries. Is he still there? Just double check, Sangeet.
No, ma'am, he is not in the meeting.
Okay, no problem. So basically, in that case, in the case discussion, what we saw, 65-year-old already reduced intake, reduced urine output, and just summary of the case alone, if we can show, Sangeet. No, go to the previous one. Previous, there is. See, 65-year-old with carcinoma buccal mucosa admitted to palliative care unit. And already, let's see, the other thing. Okay, come back. The thing, low urine output, low intake, and nearly like low blood pressure. Everything, it is almost like end of life situation. Come to the discussions. Like, okay. Rather than how to manage, what is that you have to convey to how to convey the message to the family about the patient's condition. 1 and 2 can be taken together. How to handle the socioeconomic situations of the patient. For 1 and 2, what are the options or choices? After today's topic, anyone can say, what is that you have to do? How can you deal with this? How many? Nearly 40 of them are there. But everyone is so quiet. What is that has to be told to the family mainly, because how to manage the situation. Patient outcome from disease have to be explained. Yes, very good. At least Manjula is typing something. True, very good. Patient outcome from disease have to be explained to the patient and the family. Exactly. So you may have to do it separately, or together, depending on if there is, you would have had communication sessions and everything before. So if there is no collusion already, if the diagnosis has been told, yes, and make the decision. Exactly. First job is to explain to the patient separately, to the family separately. And then if they both have conveyed to each other, there is no collusion means, then you can do it together also. Explain the condition, explain also what happens if treatment is done, explain also what happens if treatment is not done, because the patient is already in a state where blood pressure is low, urine output is low, intake is not there. So these are signs of end of life care. These are signs of end of life. So at that time, what is the care you will do? So that the patient's condition has to be explained to both, and then you convey. Then socioeconomic situation means basically you have to see what is the cultural situation. You don't harm or disrupt or disrespect any of their cultural, social situations. Give due respect for everything and then convey and tell, because everyone will not be from the same type or same group. So don't force anything, but give due respect and go ahead and do. Okay, next is, what are the health challenges of the patient? Patient already no urine, no intake, no urine output, and so I'm going to ask you one thing, because commonly you will all be faced. They may say, because patient is not eating and drinking, we want to give something for the patient. In this situation, already BP low, pulse, heart rate, everything is low, patient not eating, drinking, blood pressure is also low, everything in that situation, they say, no, we want to feed the patient. What will you do? How will you manage that situation? How many will want to go ahead and feed? How many will want not to feed? And give me the reason for both. Okay, what are the benefits of feeding in this situation? Is there any benefit of feeding for a person who is in this state? Again, like we saw today, is there any benefit or is there any harm? Subcutaneous infusion. Will subcutaneous infusion for instead of feed help? Subcutaneous infusion is a very good option at end of life care. I don't deny. Can you tell anything more, Manjula? Don't think that I'm picking you all the time, because nobody else is answering. At least you're answering. So it will be for your best benefit if you could say. Are you working in any palliative care unit, Manjula? Can you unmute and speak, please?
No, ma'am.
You're not
Hello?
working in. So where are you working?
I'm working in pulmonary department.
Where?
KIMS Attawar.
Huh?
Attawar, Mangalore.
Mangalore. Okay. Okay, thank you. So basically, subcutaneous infusion is one of the options for end of life care. But my question was, will feeding help in this patient? Ideally, no, because the patient is already the family will always be thinking, because food is one way of love or affection, and they always feel indebted. That is, if they don't do anything, they feel not okay. That as though the patient, they are not feeding the patient, they may think that it is they are depriving. But you have to say again, as I said, risk benefit or harm and benefit. So these type of patients, by giving food or fluid, anything, will they be able to correct the actual problem? No. Next, by giving fluid, they may cause harm. Already no or reduce enough food, they may push the patient into fluid overload, pulmonary edema, and they may cause more harm and they may cause death. So this, all of you remember that like seesaw slide that you saw on the harm and benefit. That is what that is called as risk benefit ratio or harm and benefit ratio. You have to see which is better, and always the benefit should be better. If the harm is going to be more, then you should not do that. That is where your job is to explain to the family and tell them, and then you can understand. And subcutaneous infusion, you would have all had a session on it. So what are the benefits, where it can be done, where it should not be done, what can be given, everything, that is one of the options which you can adopt. And then already I said, no, counseling the patient about rehab is not in this stage. That has to be done earlier. And now maybe you have to do what can be told to the patient. That's what we saw as 1 and 2. How to give psychosocial support for the relative, that is bereavement support. So bereavement support as such, bereavement itself is bereavement and grief itself is a big topic by itself. But you can have different types of bereavement. It is not just what happens at the time of someone who dies. You have to have in mind, it may last for some period of time. That is why you would have all seen when you saw about a graph on what is palliative care. Palliative care starts from the diagnosis, goes all through a long end of life and bereavement support. So bereavement support goes beyond death. We look after the family or the survivor for few months. Regular follow-up is done, then telephone follow-up can be done. All that is done because the surviving family may have different types of grief. And the grief may be, again, in that also you have stages of grief and you have something called as types of grief. So the grief can last from few weeks, few months to sometimes even 1 year. So all that should be kept followed up, and the patient has to be followed up in bereavement support also. So that is the support which has to be given for the surviving family and relatives. Okay, we can come out of this and then if there's anything else to be asked, and then we'll hand it over to Shibat. Any doubts, queries in the whole topic? Because this is something very important, and you may all have had either doubts or if at least if your doubts have been clarified, that at least will be a good thing. So let me know if you have any queries or doubts, or else Shiva, you can take over.
Madam, mercy killing is the same, madam.
Pardon me? No, mercy killing and euthanasia are same.
Okay.
Is that clear?
Yes, madam.
Okay. And that is illegal. So basically, as I've said again and again, euthanasia is illegal. It is an active act. It is not mercy, because everything, that's all some twist of words.
Ma'am, anybody have any doubt? I think, ma'am, we can wind up. They don't have any doubts. So this is their last day. We need to take their feedback also.
Go ahead, Sangeet and Shiva, you can go ahead and get the whatever, no, because it's, as you said,
Yeah.
we need to get their feedback also.
Yes, ma'am. Yes. Thank you, ma'am.
As Shiva ma'am said, today is our last session. We believe you all had an enriching learning experience just like we did. We wish to like to hear from you how you feel about the entire program, what all went good, and what are the areas with scope of improvement. Could you please tell, could you unmute yourself, or can you put in the chat box as well what all are your feedbacks? And accept. Thank you.
The positive point is, madam, we have learned many things, but the negative thing is net connection was sometimes not proper, and sometimes we become because of the work we may join little late, so that is the only negative point. Otherwise, all presentation and the cases were discussed very nicely. We learned many things.
Thank you, Ramani ma'am, for the valuable feedback. Thank you.
Just one thing, Sangeet, net, maybe from their point of view, net was not good. From our end, net should have been good. Is that right or not?
Yes,
Just
yes,
correct me if I am.
Yes, ma'am, absolutely.
Yes, madam, because where we are working also, that we have to move around to catch the link. So from our side only, the problem is most of the time.
No, see, exactly. Don't think. I just wanted to make sure, no, as Sangeet always say, we always try level best to improve our level. So that is why I just wanted to double check. No worries. Thank you. As
yes, madam.
see,
Sure.
whatever,
Yes.
one thing, whatever you have missed or something, you should try to go back and use the learning material available, and preferably try to do it and complete it now. Don't think that if you do everything once now and keep, then as you go on seeing more patients and doing things, it will be more beneficial rather than piling up and thinking when I get to see such patient. No, you should already know before, so that when you see a patient, you will put 2 and 2 together and start working on it. Okay. So humble advice would be all of you to cover everything that you've been covered here. That is the best way forward. Don't keep it for you. You've attended this course. You should follow, at least read everything once and keep. Then you can revise, repeat, rehearse, read again, then master it. So at least once you should have all covered whatever is needed or covered in your sessions.
Positive feedbacks are coming in our chat box as well. Thank you, Manjula. Thank you, Rita. Thank you, Shanti. Thank you, everyone.
Thank you once again for joining the session. Thank you, Radha ma'am, and thank you, Shiba ma'am, for joining, and thank you all others. And yeah, keep updated in the WhatsApp group, and relating to the assignments as well. Make sure that everyone submit their assignments on time, and also the certificates will be issued only based upon the attendance basis. So like criteria is there, so above 80%. So if you have any queries or anything, you can reach out to me or Sangeet as well, or you can drop a message in the WhatsApp group as well. So thank you all. Thank you everyone.
Thank you everyone for joining the course. Thank you. Bye. Thank you,
Good
Radha.
wishes.
Thank
Good
you.
wishes to all of
Bye-bye.
you. All the very best. Thank you.